Thank you all for coming for this session, and you are all should be happy that I did not do what they asked me to do, which was dance to the opening music, so we're off to a good start. Now, they've got my slides up here. There we go. So my name is Craig Stephen. I'm your co-chair with my colleague Chris Walzer, who'll come up here in a moment and help moderate the session. I'm from the McEachran Institute in Canada, and we're going to talk a little bit about this idea of intergenerational, interspecies, One Health, equity. So it's always good to start with the basic principles. And in many ways, today's session is just an elaboration of the Ottawa Charter for Health Promotion, which I'm sure many of you are aware of. First articulated in, I think it was 1986. I've always come to this section of the Ottawa Charter. I think it's the one section that One Health needs to really embrace, that the overall guiding principle to be healthy is to encourage reciprocal maintenance, to take care of ourselves, our community, and our natural environment. And you see I've highlighted the "and" on that. And I think that's really at the heart of what we're wanting to do today. So often we see the environment and animals as a source of harm, as opposed to an asset that we need to care out together so we can survive the challenges we're all facing. So again, not that you won't know this, but I want just to remind us, one of the foundations of health promotion is health equity, where no one is kept from reaching their highest level of health because of social position, social identities, or where they live. We want to talk a little bit more of that. And one of the inspirations behind this session was really featured on a meeting that happened, just last week. It's the idea of breaking barriers, advancing the One Health agenda with a focus on the environment. This idea of how do we now start to think of One Health as one collective health? That the one is the place that we share together where we can work and thrive and survive, whether you're a polar bear or a person or a pine tree. So we had a very interesting discussion, and there's information on the website from that's up there, and you see there's a little code you can look on to find that. But it brings us the idea that health equity that we talk about usually maybe isn't sufficient for the new world. We need to think about the fact that the actions that we take to protect one species today, most often us, should not compromise the ability of other generations or other species to meet their health needs. This is not a new idea. This has been the foundation of many Indigenous peoples' views of life. It's been the foundation of eco-health. It's been the foundation of many others. But I think it's a really important reminder right now that conservation is public health for the future, that we have to make sure we meet today's needs while still meeting tomorrow's needs. To do that, we have to articulate this idea of a continuum of care. We hear about that if you're in clinical medicine, that continuum of care, but we have to go from managing the health impacts on health security, on economic security, and environmental security by making sure that we're affecting the circumstances of living, the threats and vulnerabilities we have, but also the capabilities and resources we use to stay well. And those are largely affected by the health assets we have, our natural capital, our social capital, equity, and our evolved capabilities, as well as the relationships we have with each other, with our places, with our species and generations. So you see, to really maintain health through time, we not only have to limit the impacts of the bad things that will happen, we don't only have to just reduce the vulnerabilities and risky circumstances that we all can be confronted with, but also protect those assets for health and resilience. So we have those capacities to adapt to whatever life might bring us. And we have to do that in a way that integrates the well-being of all species on land. So our hope really for this session is to hear some examples. We have some very exciting speakers that Chris will introduce to you momentarily, who are bringing in their experiences of trying to work along this continuum of care, to try to think about how we believe health is a whole. And health for all is not just all people, but it's all things. And I hope that you're going to believe in the feasibility of this approach by hearing some of these experiences. I hope you can go away imagining a pathway for action that you can start to bring this into your work or your policy, your lives. And I hope you all go away as passionate advocates for applying this idea in policy and practice. And with that, I'm going to turn it over, introduce my colleague, Dr. Chris Walzer from the Wildlife Conservation Society, who is going to come and present our groups to you. So thank you very much.
Thanks very much, Craig. That was a great introduction. And thanks very much for sticking with it through the last few weeks as we pull this together. Thank you also to this amazing panel we have. Thanks all of you for coming and making the way to come here to Berlin today, and thank you all for coming to this session. My name is Chris Walzer. I'm a veterinarian by training, and I'm the Executive Director of Health at the Wildlife Conservation Society in its global programs around some 55 countries around the world. The way I'm going to do this, and I've discussed this with everyone, so I'm not going to surprise anyone. I'm going to introduce everyone as they come up and then speak. And we're going to start with my colleague, Dr. Stacy Jupiter, who's an ecologist by training and is now with the Wildlife Conservation Society, where she's the Melanesia Regional Director. And she's going to show us a real a really great One Health project to get us into what are we talking about when we talk about environment and health. Stacy, you want to come up here? Oh, I probably have to do something here. There we go. There you are. Excellent.
Excellent. Thank you very much, Chris. Good afternoon, everyone. It's my great pleasure to be with you here today to share some lessons and examples from, as Chris said, from a One Health Planetary Health project, what we call the Watershed Interventions for Systems Health, or WISH approach. I'm going to start with a little origin story about how the WISH approach came to be and tell you why it's particularly relevant for application within the Pacific Islands. But first, one of the purposes that Chris and Craig told me about this session was to expand everyone's minds about how we conceptualize health. And so I wanted to give you another way of thinking about health from the Pacific. In 2009, my colleague Aaron Jenkins, who was then running the Wetlands International Oceania office, and I co-hosted Fiji's first ever Eco Health Forum. And our keynote speaker gave a very powerful opening statement that I'll just paraphrase right now. And that was that in the Fijian language, the term health can be defined as the ability to undertake cultural practice. In Fiji and across the Pacific, cultural practice, an example of which you can see in the photo here from Papua New Guinea, is intimately tied to the state of the environment, as well as people's ability to access and use natural resources. Now, across the Pacific Islands, local people have a strong ability to make decisions over how the land and the sea and the fresh water are used and accessed, oftentimes all the way from the tops of the mountains, all the way out to the coral reefs and beyond. And this is because they have tenure and use and access rights that are in many cases enshrined in local law and constitutionally recognized in some cases. In Melanesia, where I work, in the countries of Fiji, Solomon Islands, Papua New Guinea, Vanuatu, between 87 to 98% of all of the land is legally owned by indigenous peoples. They therefore have have developed strong cultural obligations to look after the places over which they have customary rights. And thus, people are willing to make sacrifices now, within some constraints, obviously, to ensure that future generations will have the same opportunities to earn livelihoods and undertake cultural practices built on this healthy environmental foundation. That said, there is landscape and seascape transformation across the Pacific, like across much of the whole world. This is due in part to commercialization of natural resources. And through these processes, there's been a bit of erosion of the traditional knowledge systems and the customary governance systems upon which a lot of the local natural resource management is based. So a lot of what we do as a Wildlife Conservation Society in the Pacific is try to revitalize those local knowledge systems and those customary governance systems that underpin natural resource management, which ultimately is the foundation for good health and well-being. So in doing so, one of the things that we do is try to provide the indigenous landowners and rights holders with information to inform better decision-making. And we've spent a lot of time collecting information either through modeling studies or collecting empirical data that show the links between upstream activities within watersheds and how that leads to impacts downstream. So this is just one example of some modeling work that we did from Solomon Islands, this particular island here called Kolumbungara, where we modeled what would happen if the upstream forests were cleared. And what we found was that even if the forests were cleared using international best practices for logging standards, the downstream water quality would exceed international standards for drinking water safety 40% of the time. We've done a lot of further studies across the Pacific, in Fiji, Solomon Islands, PNG, that has shown in various ways that upstream watershed activities, including logging, including agricultural expansion, is related to reductions in the diversity and abundance of fisheries resources, both freshwater and marine, that people depend on for food. And yet when we present this information back to the landowners and the rights holders about the impacts to their drinking water, about the impacts to their food, we've done this in a number of ways, through posters in local language, through documentaries, even comic books and puppet shows. People get momentarily disturbed, a little bit upset, but ultimately this has not led to transformational behavioral change at the scale that's needed to be able to improve the outcomes downstream. So we really needed to radically rethink how we could communicate these issues to influence that behavior change. Now, our watershed moment, so to speak, came starting from around 2009, 2011, 2012. Fiji started to experience these very severe floods. And coupled with these floods, we started seeing peaks in waterborne bacterial disease like leptospirosis that you see pictured here, as well as typhoid, and other types of water-related diseases that seemed to lag behind these flooding events by a couple weeks to a couple months. And so this led us to think that while if you put these together, we came up, myself with my colleague Aaron Jenkins, with this conceptual model and kind of a hypothesis of how this system would work, where there's a perfect storm, heavy rain from these cyclone events or low pressure systems combined with heavily altered watersheds leads to these various interacting pathways to ill health. So in 2011, we presented this idea to a suite of donors to try to raise funding to investigate some of these mechanisms, to build the evidence base of why you would do integrated watershed management to get these win-wins for public health and environmental health. We got some interest from the donors, but ultimately they said, we've got a public health program, we have an environment program, we don't know which program officer to give it to, we're going to restructure, come back to us in a few years. We couldn't wait that long. And so Aaron closed down Wetlands International Oceania. He went back to do a PhD to try to see if he could uncover any environmental determinants of typhoid incidents in Fiji, and I helped co-supervise the work. And indeed, he found that there were various factors operating at different scales within the watersheds, at the landscape scale, at the residential scale. And this was coupled with other research that was coming out at the time that similarly showed landscape and climate variables linked to risks of other types of water-related disease. At the same time, there were traditional public health approaches that were happening within Fiji. There was a case control study that was looking at typhoid. We looked at what the risk factors were coming out of that study, and which led us to really conceptualize that if we want to tackle health in a holistic way, we have to take a systems approach. And we have to be looking at the risks and the opportunities to mitigate those risks that are occurring at all of these different nested and connected subsystems and the interactions between those systems. So at the landscape scale, we need to do things like protect the existing forests and restore degraded forests, particularly along waterways. At the residential scale, we focus on things like improving water and sanitation infrastructure, as well as livestock management. And then we do things like encouraging wash campaigns to improve hygiene. So we've put this all together now. We've been implementing the WISH project in Fiji since 2018 now. And we actually couldn't get funding from a single donor still. Aaron was able to get money from the Australian government to look at integrated watershed management for what Fiji calls its three plagues, leptospirosis, typhoid, and dengue. And I was able to pull together funding through Bloomberg Philanthropies to look at integrated watershed management for downstream coral reef health. We geographically overlaid the projects, we combined our project teams, and we've been working across 5 watersheds in 29 communities using the approach that you can see on the right here. What we do first is we get free, prior, and informed consent from the local communities, which is very important. We then collect information to assess what are the baseline risks, and we communicate this information back to all of the local landowners and rights holders. And then we start and work through a participatory, facilitated water and sanitation safety planning process, the outcome of which is a suite of priorities for watershed management interventions that either we can implement as a project team, the government partners can implement, or the community members can implement themselves. And then we monitor change. So there hasn't been that much time since a lot of these interventions have gone into place, but we're already starting to see reductions in risk, particularly from some quick win actions, things like tethering livestock and keeping them out of the water source, improving water infrastructure, distributing wash kits. And we've seen a number of communities move from high risk categories to low risk. I'm happy to say that we finally have received funding from a single set of donors to enable us to replicate this approach in other places in Fiji, but also scale it to Solomon Islands and Papua New Guinea. Now, my wish is at the end of this project that the implementation doesn't stop. So in order to get there, what we are trying to do is work with partners to develop innovative sustainable financing mechanisms, and then also design some decision support tools. So if we had the money, we can advise where to invest it for quick wins. We're also trying to influence policy dialogue in the region. We're doing this through white papers. We have a new best practice guide that's being launched today that is advising on how environmental practitioners and sanitation practitioners can better work together to improve coastal health. And we're hosting events to kind of allow people to get together, like we're having discussions here, to discuss how we can better together advance a One Health approach. So I'll stop there and say thank you very much.
Thank you very much, Stacey. And I think that's a really great introduction, right? Top-notch science, creative funding, tenacity, right? You got to keep going, right? We don't always want to know how many years this is taking to pull these things together, get those papers published, get those grants funded, and then translating that science into policy. We'll come back to that. So, Minister Katabi from Belgium, the Minister of Climate, Environment, Sustainable Development and the Green Deal, was so gracious to join us today. She would have joined us. She would have loved to join us. But as you know, because of the terrorist attacks that occurred last night in Brussels, she's unable to join us. She's on calls all day, of course, today. So first of all, please, Evelyn, convey our thoughts to Belgium and obviously to the families. We think of the families of the people, football fans, right? This is crazy. This is a crazy world. Every day now when we wake up, something crazy is happening. But we're most grateful for you, Evelyn de Costa. She's a medical doctor and an advisor to the minister to agree to come and sit in at short term on this panel. So Evelyn, the floor is yours. Thank you very much.
Good afternoon, everyone, and thank you for the lovely words, Chris. I would like to start with the fact, a fact that only last month the Stockholm Resilience Center quantified all planetary boundaries for the first time. That's a very good thing. The only bad thing about it is that already 6 of 9 of them are transcended or are transgressed. 6. This is tremendous. And humanity, it means that humanity has taken much more than we actually can take. It has taken much more of the safe operating space we are allowed to take. And because of that, the resilience of our planet, but also the resilience of our ecosystem and of ourselves, our human health, is actually endangered. And we should acknowledge that. It is a perfect example of what has been presented here before. It's the perfect example of One Health, the importance of how ecosystem health, animal health, and human health are interrelated. And the data are very clear. The environment has an enormous influence on our human health, a triple environmental crisis with biodiversity loss, climate change, environmental pollution is very important to our human health. And these health problems include pandemics, as we have seen in the last couple of years, but also problems on food sustainability. So it goes way beyond just pandemics or AMR. Additionally, we must also acknowledge that those ecological problems and those health problems are both related to also social and economic factors. And this is something we really need to take into account. So let me start first with the One Health. We must really strive for collaborations and solutions that lead to co-benefits both for environment and animal health, as well as human health. And therefore, we really require ambitious politics, ambitious policy actions, both on a national and an international scale. So we really need to embrace One Health. This interconnectedness is very important also nationally in our Belgium state. We have a federal public service where One Health is at the core of our federal public service. We have both environment, animal health, sustainability of the food, safety of the food chain, and public health in the same federal public service under the same director. This means we can really collaborate in a more integrated way. We also have a dedicated group of people working on One Health, including, for example, sustainability of the food chain, but also about preventing zoonotic disease emergence, about antimicrobial resistance. Is it already perfect? No, we should do better, but it's a start. On an international scale, because it's an international public, of course, we are also a very strong advocate for One Health. Belgium was at the 7th Ministerial Conference of Environment and Health in Budapest last July. We committed there to make our health system more sustainable, but also adaptive, and to make sure that we also not only make sure that we can adapt to the climate change, but also not try to make the climate change even worse, because the health sector is also an important factor in that. We are also very welcoming and supporting the integration of deep prevention in the new WHO pandemic instrument. It's the most effective way to prevent disease. It's like they used to say, prevention is better than a cure. I don't need to add any words to that. Lastly, I also want to stress the importance of other international projects like PRISODE. There's an international project about the emergence of zoonotic disease and how to prevent it. Because we are talking a lot about surveillance, how to attack pandemics, how to treat people, but the first thing we need to do is how can we actually prevent people from getting sick? How can we restore the balance? How can we make sure that our ecosystem is worth calling it an ecosystem? We have a lot of work going into that as well. So I've been talking a lot about One Health, but it's insufficient. We are very convinced that One Health on its own is maybe not a little bit too limited. We really need to incorporate also the social and economic circumstances in this discussion. These are very important factors for the way that people drink, behave, how they work, where they work, how they live, and they're very influential on the way their health is gonna be. If you work in an unhealthy environment, if you live in an environment that can be flooded, then of course this will have tremendous effects. So we need interspecies equity, of course. We need intergenerational equity, but also intraspecies equity, equity between people today and tomorrow. And this is at the core of the green transition. We need a just green transition. And it is one of the priorities of my minister, Minister Zakia Katabi. On a national scale, we have invested a lot in this. We feel that the social dimension, the environmental dimension, and the participatory dimension really need to be integrated in this just transition, what we want for the future. And over the past 2 years, our minister has been very involved in this, with the primary objective of really fostering a democratic discourse regarding our 2050 trajectories, which will really incorporate just transition into it. These socio-ecological aspects are indispensable if we talk about health. It not only includes human health now, also the future of populations and between populations. It's also the health of other species. It's the ecosystems that surround us. It is one continuum, as has been said today. We need to consider the functional upstream ecological and social processes, as well as the implications of our actions today and tomorrow. We need to balance all these aspects to achieve the common goal of health and sustainable socio-ecological systems. Thank you.
Thank you very much, Evelyn, for that summary. And Evelyn basically addressed exactly what we're talking about, this expanded continuum of care to include environment in the sense that we, coming from the environment sector, see environment. Those are the things outside the buildings, beyond the roads, beyond the offices. There's a bigger environment out there than is often discussed in a normal socio-ecological model of public health. There's something to expand. Craig and I would be very happy if you looked at our paper, which we just got into, Frontiers in Public Health. You have a look at that. It's not perfect, so we'd really be happy to have a dialogue on the basis of that. So thank you very much, Evelyn. It's my absolute pleasure now to introduce Rhoda Van Jense. She's a professor and dean at Makerere University, the School of Public Health. She has a really large experience with infectious disease and obviously also with capacity building. Rhoda, do you want to come up here or do you want... I think it's nicer up here.
Thank you, Christian, and a good afternoon to you all. I do appreciate the opportunity to share our experience from the academia and research side of things. And first, I wanted to emphasize that a lot of the issues we are discussing are not entirely new in public health. And I was just reflecting back when I was a student about a lot of these concepts and the interconnectedness between the animal, the human, and the plants and the rest of the larger environment out there in a number of concepts. And I recall my first lecture in epidemiology thinking about infectious diseases and the epidemiological triad and thinking the host, the agent, and the environment, and really looking at these issues and thinking back decades. And I feel this is not entirely new. We knew about this interconnectedness. We knew about the environment, whether it's the water or whatever other, as we hear, and how the disruption of this actually causes ill health for humans as well as animals, and affects our environment. It's a whole cycle that we've talked about. And then also thinking back in terms of the determinants of health, again, very old concepts that we've gone through for quite some time, thinking about health, thinking about the social, the economic, and the broader issues around the environment as we know them at this point and as we emphasize. So when I think back, I feel like we know so much about One Health. We know so much about the interconnectedness. But I think what has been lagging for quite some time is the action, that coordinated action and being able to move these things forward. And again, we can think very big. We hear really the huge global as well as national level programs from the examples from Belgium, from Fiji, and from everywhere. But when we bring it down to what can we do at individual level in terms of our spaces to be able to act locally as we think bigger beyond ourselves, I think that can help us move forward. And I've been listening to a number of sessions through this conference and talking about the key challenges and all the problems. It's refreshing to have this session thinking about what have we actually done. And I'm happy to contribute to that as well from our perspective. So locally, for us in Uganda, we moved towards a program-based approach is what we are calling it, because we have the silos across sectors within government, but we also still have those in academia. So within government, we've moved towards that program-based approach where health should now be working in a more coordinated manner with the environment, with education, with gender. So hopefully that is going to help us at policy as well as program implementation level. But within academia, we are also making some strides. It takes a bit of time sometimes to even just review a curriculum and change it. But for almost 10 years now, we've been working on what we call the One Health Institutes, and I see one of my colleagues here who has been part of this. So the One Health Institutes bringing together students from public health, students from veterinary, bringing together students from humanities and agriculture and other disciplines to work together, to learn together, to resolve challenges within the community together across boundaries, and also to be able to do their research together. But recently, we also went through a process of reviewing our curricula, our academic programs, and identifying areas where we can integrate these concepts so that we are able to support our students and future generations to think and act differently in this respect. So while we are also working on that, we have also established collaboratively a Center of Excellence for Sustainable Health, as we call it, between Karolinska Institute and Makerere University, and it's now about 3 years. And one of the concepts we've integrated is sustainable health, which is looking at health for today as well as health for future generations. And in this, we are looking at issues like the climate and how that affects the environment in which we live, and our health today as well as health of future generations, to make sure that the actions of today are not compromising the health of future generations. So this is still young. It's only 3 years, but we are making progress in terms of the work that we are doing in this space. And we are also working collaboratively with the Ministry of Health. Again, we have a team that's doing a review of the health sector and thinking about the issues of preparedness in terms of climate change mitigation as well as adaptation. So we do have some efforts that we are implementing on the ground to be able to, from the academic perspectives, improve the education as well as research and engagement. And then thinking about the bigger issue of equity as well. Again, it's another concept that we talk about for a long time, but we need to be finding practical examples of what really works. How do we define it? How do we track it? How do we identify who is being left behind? And how do we make sure that we act on it? Again, we have done a few activities related to this, and I'll just cite one example. Specifically, it's not necessarily in One Health, but we've started an equity agenda in sexual and reproductive health, where we have worked with the Ministry of Health to set up a team, including the local definitions of what it will be for Uganda, agreeing on minimum set of indicators that we can track, agreeing on the data sets that we can use to be able to do this, and being able to analyze and get this data back. And we've also recently, and that we've done in collaboration with the FHI 360, but we've also recently reached out to the Ministry of Health in Ethiopia that has a very comprehensive equity plan that is being implemented across the entire health sector to see how we can exchange and learn from them as well. So there are examples of what is really happening on the ground in terms of how we can move this equity agenda forward. And we also did, through this effort, send out a tool, very brief tool with a few questions to several regions around the world to find out who is doing anything about equity, what exactly are they doing, and what are they learning. Because we realize there is a lot around identifying inequities, there is a lot around talking about this in conferences, but in reality, on the ground, we are not necessarily having a very systematic effort of identifying who is being left behind and acting on it. And as we do this, I'll just flag some of the issues that we see as the next steps and where we see gaps. Improving awareness around these concepts, although they are old, they are not as widely known because for some reason they slipped through over the years. The One Health issues, improving issues around awareness around equity, especially in the broader One Health professionals space. This is going beyond the health sector to others, and raising this awareness so that they are part of the solution and they are thinking about how, as individuals or wherever they are placed, they can be able to contribute to this, but also getting communities engaged and being part of the solution, I think is something that we need to think about. Who is being left behind? The vulnerability, mapping, assessments, and the effects of what's happening in the environment on individuals, as well as what they are doing themselves to mitigate this. We need to do more about that. But finally, just to note that these equity issues are quite dynamic. In our experience as we work through this, we realize that a population that's not vulnerable today can be vulnerable overnight, whether it's because of conflict, whether it's because of effects of climate, flooding, or drought, or whatever. So it's a very, very dynamic issue, and we need to be pretty prepared to be able to continuously identify and address vulnerabilities. And then finally, just to note that our challenges are still great and we have a lot to do. But I feel energized myself listening to examples of what's really happening on the ground and what has worked. And I hope we can spend a bit more time documenting what has worked well and how we can learn from it so that we can build on what is going on. Thank you.
Thank you very much, Rhoda. So I think we are the worst and beating ourselves up, right? This is something we need to get over as well, right? A lot is happening, a lot has changed, a lot of good. There's a lot to do, but we're also really good at saying, oh, nothing works, right? These are examples, we're only halfway through the panel. These are examples of things that work. We need to stop, or we need to change that narrative to, we know how to do this. You need to learn at the governance level, at the funding level, to help us turn this into action. We know what needs to be done. We're going to keep learning, but we do actually have a plan. So, talking about governance, it's my really great pleasure to ask Dr. Katie Wollaston, who's an interdisciplinary researcher, lawyer, and senior lecturer at the School of Law at the Queensland University of Technology. I also don't want to miss pointing out that she just published a book. It's hard to sell books, so all of you listen to this. Especially when ecological vulnerability, the law and governance of human-wildlife relationships at the Cambridge University Press. I would suggest you all get that because there aren't many books out there on that subject. Katie, would you come up here? That'd be great.
Perfect. Thank you. Thank you, Chris, for plugging my book on my behalf, and feeling very humble about that right now. Thank you for having me, and welcome everybody. Thank you for coming. I would like to go back to what Chris mentioned, a comment that he made a few minutes ago about One Health potentially not being fit for purpose in terms of intergenerational and interspecies equity and how we might make it so. So I want to start by saying that I believe One Health can be fit for purpose for this reason, and that the One Health framework certainly represents an opportunity to fundamentally shift the way humanity views and governs its relationship with the planet. By definition, the One Health framework should be focused on interspecies health, equity and justice. But post-COVID-19, not that we're post-COVID-19 yet, but post the onset of COVID-19, we as nation states, as governments, as councils, as practitioners and researchers and whatever other role you have in this room, are returning to a business as usual approach when it comes to One Health, in practice and in theory, even after all of the One Health work that's been undertaken post-2020. Excuse me. So, why are we not making fundamental shifts in our governance of human and non-human environments and species as a form of the action that Rhoda mentioned earlier? There are undoubtedly many reasons why. I want to potentially talk about three of those. So the first one is actually the second point on this slide, that One Health is still seen as a public health framework, at least in terms of how we integrate it into law and governance. But public health is a component of One Health, not vice versa. And I know that might be a very controversial statement to make at a World Health Summit, but is how it works. We know that the environmental drivers of pandemics and other health issues, not only pandemics, environmental drivers of other diseases and health issues globally, are not being appropriately governed. We are off our climate targets. We are in the midst of a mass extinction crisis, and our laws and policies are not working to resolve these. But One Health governance and programs mostly remain centralised in our health departments or our biosecurity departments or our CDCs. So what that means is that we aren't getting the funding, the research and the laws that are needed to address deep prevention of these health issues and that we need for interspecies and intergenerational equity. Just as an example, in Australia, once it became clear to the Australian government that H5N1 was going to be a particular problem, they invested 623 million Australian dollars into research associated with H5N1. Less than 10% of that funding went into improving prevention and detection capacities, and none of that funding went to the environmental drivers. There is also a missing governance link. We now have quite a solid theoretical base for One Health and framework building of One Health, and many, many examples of on-the-ground One Health activities, including Stacey's project and others that we're going to hear about. We still, though, largely lack the institutional and legal support needed for longevity of those projects and upscaling of those projects, like as Stacey mentioned in terms of her project. We need the institutional and policy legal support so that when someone walks away from those projects, they can continue on. Finally, One Health scholarship and practice requires decolonisation. This is so important. One Health has been designed in the West as a Western framework, but is certainly not a Western concept. As Craig mentioned, Indigenous communities have always connected their own well-being with that of the land around them. In Australia, Indigenous managed lands have biodiversity values that are actually higher than the protected areas that we protect in our laws. Indigenous land management practices are associated with improved biosecurity, protection of threatened species, improved fire management, and greenhouse gas emissions. So not only are our Indigenous groups primary stakeholders, but they are willing, engaged, and knowledgeable stakeholders that need to be given primacy in collaborative efforts towards pandemic prevention and other general health issues. This involves us stepping back and making room for Indigenous leadership. Mere consultation with Indigenous groups is not enough. So, what can we do? This is going to sound a bit self-fulfilling coming from a lawyer, but we need to involve social scientists, lawyers, regulatory theorists, political scientists in our multidisciplinary work to build better One Health governance theory. We still don't really have a good answer to what good One Health governance is, what a good One Health law looks like. But I can tell you that it is more than having a national One Health action plan, which is what's being included currently in the pandemic treaty. The theory of One Health needs to be untied from zoonotic spillover. Again, another controversial statement probably. The OLEP theory of change seems to understand this with a much broader discussion of the health links between the environment and health, but also simultaneously focuses on zoonotic spillover. Perhaps for this reason, some groups, some organisations around the world are breaking from zoonotic spillover focus. For example, again in Australia, our primary wildlife organisation, our primary One Health organisation is Wildlife Health Australia, and their theory of change links directly to the coming Montreal Biodiversity Framework goal of people living in harmony with nature, instead of zoonotic spillover specifically, and instead of linking to the SDGs as OLEP has done. Second, we need to give time for and invest in a systems approach to regulatory mapping. This probably sounds very boring to many scientists, but it's very exciting for me. This is not something that was done in the pandemic treaty process, as far as I'm aware. Please correct me if I'm wrong, if you're involved in that process more intimately than I am. The reason why this is important is we need to map our governance systems across the environment-animal health continuum so we know where the collaborations are and where they aren't, where the legal gaps are, and how we can, and to come up with plans in terms of how we can go about fulfilling them, or filling them. Third, mainstream. Mainstreaming is a catchword at the moment. Mainstreaming involves embedding biodiversity across government policy, decision-making, and operations. Biodiversity mainstreaming has been included as a goal in the coming Montreal Biodiversity Framework, and this follows years of support around the world for climate mainstreaming. So as an example, biodiversity mainstreaming might include something like the creation of a One Health collaboration centre that sits across ministries, not under them, or a piece of legislation that sets out explicit legal duties to take climate and biodiversity into account in decision making, or having the protection of biodiversity measured as a KPI in high-level government employment contracts. Finally, we need to ensure that the evidence that we use for the evidence-based policy aspect of One Health is truly multidisciplinary, inclusive, and relevant to context. I have concerns as a lawyer that the pandemic treaty currently states in its current form that policy needs to rely on science-based evidence. It says that a number of times. Science is very important. No one in this room is going to deny that. But science is only one form of evidence. And while it's really important, it can exclude many other types of knowledge and evidence, including that of Indigenous knowledges, social sciences, and evidence relevant to social justice and equity that are crucial for ensuring intergenerational and interspecies equity. Thank you.
Thank you very much, Katie, for that really succinct summary. Now, I want you just to reiterate one thing that Katie said in a very, I think it's an Australian way of doing things. One Health supersedes, or public health is a tool of One Health. And as Katie said, that's the way it is. Basically, get over it, right? Just to put it, Austrians are quite like Australians. We always get mixed up as well. So really, that's something, the moment we waste a lot of time mixing these two up and being defensive if you're in the public health arena maybe. So that's something to think of. Katie talked a lot about traditional and Indigenous knowledge. So it's my absolute pleasure to have Dr. Mariam Wallet Abu Kreen, who is a Tuareg from Mali, a medical doctor. She's also has a master's degree in humanitarian action from Geneva, I think, is that correct? From Geneva, and a bachelor's degree in education, and you're now affiliated also with the University of Ottawa. It's quite a thing. I always think it's an amazing background, very diverse. And she's one of the leaders of the Aramat project, which you're going to tell us a lot about today, and the integration of traditional knowledge and health. Would you like to come up? Yeah. Or we can't get this thing down, unfortunately, can we? Okay.
Yeah, thank you. Thank you so much for the nice introduction, Chris, and for starting us, Craig. And thanks also to my co-panelists here and to the audience who joined in the last day of the summit. And I'm very glad to see how you are interested in this topic. The room is full. I'm coming to you this afternoon with a knowledge that was passed to me and taught to me from different elders that I want to acknowledge from both my own community, but also from other Indigenous communities I had the privilege to live with and learn from. And it comes also from my Indigenous and non-Indigenous partners in the Aramat project. So I wanted to bring you to shake our conceptions of health and well-being, or some can call it One Health, global health, with Indigenous lens. For us, the Indigenous peoples, we are all part of Mother Earth. There is no environment animals, humans, and we depend on each other to be so, and well-being and health has to be considered and addressed as one also. And that is well grounded in the Aramet concept, which we take from our project name, the Aramet project. Chris just introduced it. So for us, the Tuareg people, Kaltamashak, we think health of all together. We environment, people, and also the other species, the animals we live with, and the habitat we live with and within. So this concept describes well how we share together the space. It is well illustrated by the way we think health and well-being. For example, we would say for a habitat or a land that it is healthy when it is welcoming people, but also animal, because we are herders, so we depend strongly on animals like camels, but also we depend on the diversity of animal. We cannot just rely on one species. Each species of animals has its own place, but also of vegetals. So we can say that this place, before doing our pastoralism movement, like the transhumance, we would say like, is that place has a Aramet, meaning that it's good for us as human beings to live together, because if there is a scarcity of resources, this can lead to even conflict among ourselves, but also conflict and competition with other species. So all is thought together. There is no aspect that we can afford to live away. And I also have, from that perspective and thinking and way of living, we have a very famous verse of my people language and song that says like, if I'm ill, there is no medicine, as you can see here, like, I'm ill, there is no medicine. My medicine is the scent of a riding camel. So we can see emotionally, spiritually, how this is important, because one of the things that we are forgetting here is also the emotional, mental, and the spiritual health, which is part of health and which has consequences on the physical health also. And the other thing that I wanted to bring here is still like the way we approach health as a sustainable management case. And we are guided, as I said, through the concept of Aramet. We are guided centrally by Mother Earth. Like she guides us on all our lifestyle and how we care of each other, either humans, but also with animals on other species. And my grandma, because we use the trees stems to keep the oral hygiene. So there is one specific species of acacia that we use for that. And when we used to go as children to cut some of these stems, my grandma would say, please keep really cutting only what you need to use, because these trees are not only things you can play with. You have to be careful. They are the ones giving us shadow, and those who lived in the desert or very hot areas, you can understand what shadow means. But also we got fruit from them. We got medicine from them, like antiseptic and all over whatever medicine we use. So be careful. You need to take what you need and protect them. So that was from my grandmother, who passed away 2 years ago, and she's well known as a traditional medicine woman from Timbuktu in Mali. The same was taught to me by Elder J.C. Catholic from the Letsuke community in Northwest Territory in Canada. We were fishing together, so I wanted to learn more, not only fishing, but I wanted to learn more about indigenous-led conservation and from the water also. And when we were fishing, he told me, because we catched a young fish, and he told me, no, this one we have to release him. I asked why, and he said, well, because these ones need us. We have to contribute to their development. So when they grow, they feed us, but when they are young, it's our responsibility also to take care of them. Similarly, when he was processing when we were processing the fish, he was the one who was teaching me, and he took the parts of the fish that we don't need, like bones and head, and he started to cut them. And I asked him, Elder, why are you cutting those one we don't need? Let's be focused maybe on those we are going to cook and feed people. He said, no, who would cut them for the birds? There are birds coming, and we need to feed them also, because they cannot take big pieces. So I need to cut them for the birds, and he threw them. I have over images with the birds coming over on the cutted fish that you can see here. So that's another way on how we share with other species, but also intergenerationally. Like, I got this knowledge, and lot of other youth was part of this. It was a learning camp, and we were over to learn from conservation outside of like standard laboratories. For us, this is our schools, our laboratories, and where the knowledge is passed on. So for me, the last word would be really to consider that biodiversity and there is no division between biodiversity, over species, environment, human. We are all one, as I said. We should approach the health also as one, as illustrated by the concept of Aramat I shared with you. And for that, we need an equitable, effective representation and involvement of indigenous peoples and their knowledge systems in policy transformation, like here in the global health, because I kept heard vulnerabilities and seeing indigenous peoples being taught as vulnerable. But you saw with the two examples I gave that we are far from being vulnerable. For sure, we have been vulnerabilized because of some issues, either conflicts, deforestation, destruction of the habitat that we share with other species, but we are far from being vulnerable. We are knowledge holders, we are leaders, and we want to be at the table and to contribute to the policy transformation. We don't want to be just invited for one piece of the work, but we want to co-design, as we said in our Breaking Barrier pre-summit last week. So that's the approach that I want to invite you for. And also, lastly, I just want to explain the image here. The image comes from our Aramat project, Strengthening Health and Well-Being Through Indigenous-Led Conservation and Sustainable Relationship with Biodiversity. You can see each image, small image you see here is one of our partners. So you can imagine how many people are involved in this project, but it's also, as you can see, the tree, it's where everywhere we have trees in the world, and the trees can be very different, right? From acacias to maple trees to very different species. So that's how we stand and where this project come. And for those who want to learn more about the project, I left my contact and our website because the time is so short to explain it. But I'm very grateful for the opportunity. Tanemert, meaning thanks in my language.
Thank you so much, Mariam. Really appreciate you making the trip here and sharing your wisdom with us. So when did this happen that we don't realize we're all part of Mother Earth? What happened, right? This is something we really need to think about when we get up in the morning, when we go out in the streets. There's no reason you walk on this street, you're still part of Mother Earth. One thing I have problems with in the One Health concept, we always talk about environment, animals, and humans, as if we weren't animals, right? We're the most dangerous animal on this planet. It's our responsibility to also fix a lot of the problems that are out there. All right, so one of the problems in these sessions normally is there's no time for discussion. I am really, really excited that we actually have time for discussion today. We're going to open the floor right now for questions and discussion. So we need a microphone. Yep, wonderful. So we'll start right here. There, and then I've got the next two. Okay.
Thank you. Thank you for the great...
Can I just say one thing? Questions, right? If you want to make political statements, and I think I will cut you off, right? Just saying it right in the beginning. And that was not addressed to you at all.
Thank you for clarifying it. Okay, so I need to make this statement to ask a question. So I think Dr. Wollaston was right. Public health is part of One Health, but I don't think we need a new theory, so to speak, to publicize. When did it all happen like this? You know, whenever we started multiplying like rats and we needed more money. So public health brings money. One Health is philosophy. So that's why a lot of people are not going in the direction of One Health. So with that statement, I would like to ask the whole panel, what would be your collective message to the negotiators of the pandemic agreement? Because that's where I hear from the facilitators that the negotiating parties are not able to come to an agreement, a reasonable agreement. That's where they are pulling each other's hair. So what would be your message to all of them?
Could you just give us where you're from and your name, so it's on the...
Sorry, I didn't say that. My name is Vijay. I'm a freelance journalist right now representing Health Policy Watch.
I leave it up. I mean, Katie, maybe?
I have lots of opinions on the pandemic treaty. I don't think I have time to share them all. I think primarily, if we could have our time over again, it would begin with regulatory mapping, right? Because there's a lot of work already. There's so many treaties. We're overburdened with treaties from the environmental perspective, from the animal perspective, that are not necessarily getting airtime with respect to this treaty. Also, we would question whether this should be a One Health treaty or whether it should be a public health treaty. Because a One Health treaty is something that needs to incorporate so many different things that, and because of the time frame of the negotiations of this treaty, it hasn't been able to do that. So if I had one message for the negotiators, I would say, take the phrase One Health out. It's not, as you say, it's a theory, it's a philosophy, it's planetary health, it's eco-health. It doesn't need to be there. What needs to be there is the obligations that come from the environment, animal, human continuum, not the phrase One Health.
Okay, ouch. Chose the panel, so there you go. Could I just to that, I really have one point which I wanted to bring up the other day. I remember you asked a question in the other thing as well. There is also a disjunct between the individuals negotiating, the negotiating teams, and their governments, And that needs to be bridged as well. That is a really big problem. Governments have a capital has a completely different position than the negotiators. Just putting it out there. Please. Back there first, yeah. I got you, Sasha.
Thanks, Chris. Ben Canny from University of Adelaide. Your comment just as a segue to my question almost, so thank you. My question I want to direct to Stacey, but I think I could direct it to a number of people could answer. Stacey, I really admired the fact that you did extensive negotiation with the communities with whom you needed to work to gather the data and design the research and so forth. I also noticed that you talked a lot about your funding challenges, and a number of the funders you got might be considered foreign aid, which made me think about the whole governmental relationship. And from my accent, I have some knowledge of the geopolitical complexities of the area that you're working in. I was wondering if you'd like to comment exactly on that point of where does the government relationship operate, and how does that work with the need to actually work with the people who are directly affected by or more directly affected, let's say, by the research that you're doing?
Thanks very much for that question. Is this on? Maybe. So I'll stick with the Fiji case because that's where we've been implementing most of the project. The government, in particular the Ministry of Health and Medical Services, as well as various other ministries like the Ministry of Agriculture in particular and Ministry of Forestry, have been very supportive of all of this and very participatory in the process insofar as they've come along with the teams to all of the planning processes with the communities. They put in their own resources into a lot of the interventions, but they don't necessarily fully have the policy mandate to be able to coordinate with each other and to be able to finance things at this level. One of the great outcomes of this approach in Fiji has been through this bottom-up planning is that the risks identified by each community were incorporated into their integrated village development plans, which goes to the provincial government level. That allows for provincial government funding for some of those actions. Granted, they only have a limited amount of funding, so maybe one thing might get funded in the next 4 years in one place, right? The hope is to try to build the business case for this kind of preventative care of the environment, but this systems approach. And so what we're going to do over the next year or so is to work with resource economists and epidemiological risk modelers and say, what are the cost savings of taking this approach, and balance that out against what would be the investment to see if we could get some commitment to creating some sort of fund and then build the governance of that fund to be able to distribute the money where there's the highest risk. So that's a big ask, but we've already worked in Papua New Guinea with the government there to create their first national independent biodiversity and climate fund. So that exists. Right now it's sitting within UNDP, but the hope is within the next few years it will break out. It has its own independent governance. It'll break out into its own institution. And so there our task is to get board to see beyond just financing protected areas or climate funding for carbon credits, but to think also, again, systems thinking, can we do watershed management or WASH or areas to reduce these risks in and around our high biodiversity areas as well, to be able to, again, take this systems approach and have that funding mainstreamed, not just to receive aid, but also to get government commitment of funds. So the Papua New Guinea government has said that they are going to put a tax on round log exports and put that into the fund. So we'd like to see those kind of approaches so that you have revolving funds going into these type of funding mechanisms.
Mariam, I know we talked about this a few days ago, and I was quite impressed when you told me about your network of collaboration. And you also made this point, you've been, I can't even say the word, you've been made to appear vulnerable, but you're not vulnerable and you want to lead. So how do you deal with funding initiatives that want to interact with your project?
Thank you so much. Yeah, I thought that would come in the questions because I didn't have time to approach it. But for the funding, yeah, that has been very, very challenging part of indigenous peoples to be able to document their knowledge, and so to be able to also make ways for the transmission of those knowledges, and also to bring them to what is called evidence-based or science, because we always ask you, I'm sitting in several tables, scientific tables, and it's hard for me to bring a knowledge with a DOI or things like that that are needed to be able to see your knowledge in those publications, or to build science-based evidence. So our funding came from a Canadian fund named, just one funding institution, the New Research Frontier Fund, which is a federal government of Canada new funding, and it's on the, we got this funding on its transformation streamline. But the way this funding was set was challenging and not really appealing indigenous leaders to be able to apply, even if they were calling and indigenous peoples and said that there will be a kind of percentage for indigenous peoples if they put together a call for proposal. But that is challenging for such huge project. Is $24 million project. People who applied at the first stage, I don't remember, but at those who were able to submit a letter of intention was 300 very well advanced academics. So we had to compete with 300 very nice and well advanced project. So we had also, and we were fortunate to be working with people coming from also the dominant knowledge systems like universities, and it's through a university that our project was submitted. So the University of Alberta, that I want to acknowledge, because they helped us really, they gave us the resources to be able to work 2 years to put together that application and to be able to be competitive and to be able to be us, like to present the knowledge as it comes from indigenous people from the 7 social cultural regions of indigenous peoples. But it was still challenging because we got the award, and now we committed to award those who contributed in the application process. So it was really coming from indigenous places, and we had to award 140 indigenous place-based projects, so 70 twice. And for us, we had to not perpetuate the same things we had to go through in our application process. How can we make those applications friendly, accessible to our indigenous partners? So we had to work hardly with them in a way to be able to welcome their proposal and make them accessible, the request for funding process, but also being compliant with our funding institution, which had the standards of a high national institution. It's one of the toppest Canadian now research funding processes, institutions, sorry. So we tried very few things that I am very glad to share with you, like involving them in the application designing process, thinking of different ways of submission, for example, welcoming the storytelling as method, welcoming presentation, audio, video, pictures, designs, because that that is how indigenous people can tell some of the things they can write, being welcoming their languages also, and the diversity in languages. Because, for example, me, I'm more fluent in French. I speak French, but so the other indigenous people speaking French are left away, or Spanish, if they cannot submit their proposals in those languages. So that's our small things that we were able to do, and to update and adapt and being flexible. Was it perfect? No. There are still things that we could have done better, and the Canadian New Research Frontier Fund could learn from also, to be able to make those grants accessible. But I'm hoping that the global community would also think about that when putting together grants for that are accessible for different groups like indigenous peoples, but also women and or young professionals. Yeah, thank you, Tanimir.
Thank you very much, Mariam. That was a really on point, not only for indigenous people, young colleagues, other cultures, other languages. And it's not only about the grant writing, it's also the compliance issues. You have to be able to actually manage that grant, and you need support to do that. Thank you. Anyone else? I saw you, Rhoda, you were going, yes, I've been there. I know this. You're welcome to comment if you want, but I think the point's, otherwise it's a call to the donor community to think about this. And we can come back to it. Maybe Sasha, you want to ask your question?
Thank you. Sascha Knauf, Friedrich Loeffler Institute. I have a question to Katie. If we talk about One Health, and from the lawyer's perspective, what do you think? Do we need also to have a critical revision of legal systems? Because we face substantial conflicts of interest within One Health. To give you an example, if we killed 60,000 chicken because there's an avian influenza outbreak nearby to prevent the spread, then it's certainly not in the health of the chicken. So, and this comes along with a lot of conflicts that we are facing, because we always trim the system towards human health, of course. I understand that this is the way it should be, because we are all humans and we are all interested in our own benefits. But if we really consider One Health, that really means One Health and not human health, right? And concerning the local knowledge, I think we all agree that local knowledge needs to be recognized. But in my view, and also per definition, I think, local knowledge means it's a small proportion of beliefs that meet the scientific standards for evidence. So I think it's not conflicting with the term of evidence. And I think if we are evidence-based, then local knowledge is also, in my view at least, included. Otherwise, we're talking about beliefs.
Katie?
Thank you. There's a lot there. I think you're right. One Health requires us to reformulate the way, not only the laws themselves, but the way we make laws. So there are going to be conflicts, and at times something is going to have to be given priority, but we need to be able to balance it in a way and just make sure we're considering the other things that need to be considered, which often aren't considered at all, like animal welfare. As you've mentioned, animal welfare is a One Health issue as well. So we need to have the laws in place that require our decision makers to at least consider and acknowledge their consideration of those things, and that's often missing in those legal frameworks. I disagree with you that local knowledge isn't a form of evidence. I think that for One Health especially, we need to make laws and policies that are relevant to context, and local knowledge is context. So when we're making laws and policies, our decision makers are not only looking at the scientific evidence, they're looking at how it's going to affect that particular community and what the equity issues are and what the social justice issues are and what the economic issues are. And they're all different forms of evidence that need to be considered. And I think the prioritisation of scientific evidence, again, while science is necessary, and again, coming from a place of not being a scientist, so I'm probably going to cop it for this from everybody else in the room, but that is multiple forms of evidence that again need to be considered by decision makers in policy making.
So just for correction, I just want to correct, that's what Sasha said. He did say it is just another form of evidence, right? Yeah, right. Am I correct? Just so multiple forms of evidence other things are beliefs. Everyone is allowed to have their belief, but not everyone's allowed to have their own facts, right? That's a good one. There's one question right in the back there. Thank you.
Hello, Carl Mastino from WHO. My question relates to private sector accountability, marketing, decolonization, and revitalizing local knowledges in a context where, for example, talking about the Pacific Island, where we have like such a high incidence of non-communicable diseases like diabetes. Why is it so cheap to buy corned beef? And everybody is buying corned beef if you live in Suva. And it's so expensive to buy locally made products, which are usually targeting tourists coming, like coconut shampoo based and stuff. So my question is, what can we do to make the private sector accountable in making these local knowledges reflected in products that are available in the market for? Thank you to Stacey and Katie. Thank you.
Sorry, I think, Rhoda, you would also have something with non-communicable diseases in your part of the world surging, is that correct? And then I'll pass it on to Tracy after. Stacey.
The broader concept of local knowledge, experience, and what works, I think is really so important for us in public health. And it's not just about the science, it's about how we design all our programs to be responsive. And that also goes for development of medical products and whether they will be acceptable or not, what concerns people might have. So I think it's something that in a way does not conflict with science, because it's the basics and the beginning of understanding the context before we design our science as well. And my belief is that even as we design our science, and as we try to go in search of the facts, we need to understand the context, and we need to understand the local beliefs, we need to understand the experiences, because that helps us to be able to ask the right questions and be able to connect and engage with the communities better. So I think that all this is part of the broader basics of good public health. And it shouldn't be a challenge, whether it's for the private sector. We've had experiences where we have products come out, the most recent being the COVID vaccines, which we assumed everybody would run to get. But we had our local communities asking whether these would work for them. And we had several people say they were not tested on Africans. They don't work for Africans. So we had those kinds of comments from our communities. So even when you're designing products, you've got to understand, and maybe you need to test them on a wider population while understanding the concerns that people might have. Yeah.
So Stacey is going to elucidate the mystery, the colonial history of corned beef across the Pacific. It's flabbergasting.
I mean, spam came from World War II, and it was packaged for soldiers, and then it was left. And some of this relates to power asymmetries in terms of there are cases in the Pacific Islands where there are certain food products that are sold in other countries, but the nutritional content of what's sold in packaged foods in the Pacific is less healthy. It's because oftentimes the companies will go individually to the governments for negotiation. If the Pacific came together as a bloc, they could negotiate with a bit more power to say, I'm sorry, sugar drink companies, you have to put a lower amount of sugar in the product. One of the things that we're trying to do and link to the Watersheds project is also, people will always choose unhealthier food in many cases because of the convenience, right? And there's the cost. And so there can be taxes that you can work towards to make those unhealthy products cost more. But ultimately, we want to make sure that there's an availability of healthy foods. And so a lot of that is trying to revitalize those traditional and local knowledge systems around food cultivation, food harvesting, food preparation. We're trying to work with elder women, especially in communities who have the knowledge that's being lost on the food preparation techniques, and then actually even prepare cookbooks with them, which we have done and we're continuing to do, to make sure that that generational knowledge is not lost. And then we're trying to work with the management of the downstream fisheries to make sure that those nutritional blue foods are still there. There's a limited bit of evidence to show that people who are nutritionally compromised are more susceptible to severe morbidity from water-related diseases. And so this, again, is kind of the whole cycle and the whole system that we need to look after in terms of thinking about ridge-to-reef management for humans and animals and the environment and people. In Pacific languages, there are terms that we don't have in English or in other Western languages, terms like vanua, fonua, puava, that encapsulates this connectivity between the tops of the mountains to the sea, the interactions between all species, and also ancestors and future generations. It'd be nice if we could figure out how to talk about it as simply and easily as the ways that Pacific Islanders do. When they say that, they know exactly what they're talking about in those connections.
Stacey. So the other day I wasn't feeling too great in the morning. So for the first time in 15 years or something, I had a Coca-Cola. I was flabbergasted. If you haven't had it for a long time, you see. Evelyn, your minister's ministry deals with food. Is there something you also tackling in Belgium, if you can speak about it?
Well, so we are on the environment, climate, sustainable development, Green Deal part, not exactly on the food. We do look into due diligence, like the food that we are importing, is this related to deforestation and these kind of things, so more about the sustainability of procuring food. So I cannot tell you about the national or federal food strategics from our point of view. I can tell you that what was pointed out about unhealthy food and being it very available in specific areas, it is actually not in specific areas, it's all over the world. It's one of the most struggling problems all over the world, that people, although we know what is good for us, don't always choose it, and even if we want to, it's not always available, or it's not affordable. So I think it's a very generalized problem. And going back to one of the questions that was presented before about how do we legally shape this One Health framework, and how do we actually balance one health against the other one. I think it's something that we do all the time. I mean, we make decisions about how to balance economic against public health purposes. We do a lot of things that are not good for our public health. So if we can do it for such a thing, why wouldn't we be able to make this balance between environmental health, public health, and animal health? Because most of the time, it will be a co-benefit. Most of the time, there will be a balance that is very easily shifted in favor of all three of them. So maybe we shouldn't focus on the negative points, because we tend to do that, but maybe we should start with the low-hanging fruit, because there is a lot of low-hanging fruit that we're missing out at the moment.
All right, thanks, Evelyn. I'll make sure we have a philosopher on our next panel. So it always breaks down to a values discussion. There was one more question. There you go. Thank you, Davide.
Hello, my name is Davide Ziveri. I'm working for Handicap International NGO, and I'm also part of the Because Health Network in Belgium. And my question is for Dr. De Koster, because we finally have a European Global Health Strategy, and I wish to ask how we can ensure that its implementation, starting from next year, could harness and promote, even mainstream, the One Health agenda in converging actions. Thank you.
Thank you for this question. Can you hear me? Yeah. So I think two things. First, make sure that everyone knows that it is important. That is the first thing. We actually do trainings for medical doctors and medical staff about environmental health, because we know people just don't know the importance sometimes. You could expand it to anyone in the policymaking world, but also to the general public health. So this is the first one. And then second one, institutionalize it. Make sure that people are forced to speak to each other, whether it be because they're in the same building and they need to take the elevator in the morning together. This is the case in Belgium. But also make sure that you have institutionalized cooperation between them. And it's a long process. It's not easy. But for example, in Belgium, we have several governments. We have the federal government, the regions, the communities. And we made sure that there is such a thing as a program where everyone works on our NEHAP, our National Environmental Health Action Plan, and all the governments have actually agreed upon working together there and making the decisions conjointly, which is very strong. And most of the time, environment and health are on the same side. And there's a lot of teams where you just can't pull them out, and they are so intertwined that it would be very strange to talk about environment against health. It's just not natural. And there are many examples. I mean, if you look at exotic mosquitoes related to climate, but also very public health impact, and there are many problems, environmental pollution and stuff like that. So I see the time is short, so I'm gonna.
Thanks, Evelyn. Thanks for keeping an eye on me. All good things come to an end. Thank you very much, everyone. I think a round of applause. Thank you for making the effort. Thank you for all of you coming here. I just want to also thank my co-host, Craig Stephen from McEachran Institute. And I want to thank my colleagues here in the room, Molly Crystal, Arno Gossens, Sarah Olsen, Louis Guerra. Thanks very much for helping us in these last weeks to get us here. Thank you all for coming here, and thanks for the technique back there as well. We look forward to seeing it on YouTube. This is all on YouTube, right? Forever, I guess. Thank you very much. All the best.